So let's start. Welcome again to our webinar about the role of metabolic and capillary perfusion in acute ischemic stroke. It will be presented by Dr. Ettore Nicolini from Sapienza University in Rome in Italy. So just some reminders. You may notice that your mic are deactivated. So you may ask questions along the talk with the Q&A part that you should have on the top bar of your screen. So don't hesitate to ask a question during and write them during the talk. You will find this webinar and the recording as a replay that we will share with you by email and also on YouTube. So we are a lot of participants tonight, so we may have a lot of questions. Don't worry if we don't have the time to answer everything tonight. We will answer by email and distribute the answers to you. And also just another event to let you know about. On the 24th of September at 5:30 p.m. Will take place a webinar at the Italian Stroke Association, so we will be in Italian. It would be presented also by Ettore, as well Professor Fenardi, Giorgio Busto as speakers, and we will have as moderators Dr. Santa Lucia and Dr. Bracco. And thank you, Ettore, to be here.
Thank you, Aurelia, for your presentation, and thank you for the opportunity to present this webinar today. I'll share my screen. Okay. So, good evening, everyone. Today I will talk to you about a new advanced perfusion method, the capillary and the metabolic perfusion, both on MRI and CTP, and the opportunities that this method can give us in acute ischemic stroke. These are my disclosures. And this is the outline of today's webinar. So first I will need to do a premise about tissue perfusion and metabolic tissue perfusion from what we know from animal study, and then what we have nowadays with conventional imaging perfusion studies. And then we will go deep into capillary and metabolic perfusion, and we'll see the data that we have to date. So everything starts, of course, from the cerebral tissue and how it responds to hypoperfusion. We know that ischemic sufferance starts from the hyperperfusion, so from the reduction of the cerebral blood flow, and in vivo studies helped us to set a threshold for the start of this ischemic sufferance, which is 20 milliliter per 100 grams per minute, in which electrical function begins to be affected. Then the more the cerebral blood flow is reduced, the worse goes the function of cerebral tissue, indeed, until the death of cerebral tissue. Conventionally, we set the threshold for irreversibly ischemic damage below 5 milliliters per 100 grams per minute. But actually, while the threshold for the ischemic sufferance is set and stable, so for what we call the penumbra, is not time dependent, for the core, so for the irreversibly damaged tissue, this is time dependent. We know that cerebral blood flow between 5 and 10 milliliters can be tolerated for up to 1 hour, and between 10 and 15 can be tolerated up to 2 or 3 hours. This is because there are other parameters we need to consider when we are talking about ischemic tissue. Indeed, the most important one is the cerebral metabolic rate of oxygen, which determines the cellular function during ischemic stroke. We know that during the reduction of the cerebral blood flow begins also the reduction of cerebral metabolic rate of oxygen, and that below 0.8, 1.7 milliliter per 100 gram per minute of CMRO₂, there is irreversible infarction. At the same time, this is possible because in the first phase, so where we have still salvageable tissue, there is an increase of oxygen extraction fraction. So indeed, while the cerebral blood flow is reliable to identify an hypoperfused tissue, it is not good to distinguish for the distinction of the tissue at risk but salvageable from the dead tissue, while CMRO₂ and OEF are definitely better. This was evident also from the first studies in human beings in ischemic stroke patients, which were the positron emission tomography studies, in which it was confirmed what was seen in vivo study, so that indeed in the ischemic core we have a reduction of cerebral blood flow and CMRO₂ with variable OEF, while in the penumbra we have an increase of oxygen extraction fraction. Indeed, a cerebral blood flow reduced below 20 milliliter with reduced CMRO₂ but an increased OEF allows us to detect the penumbra in the PET studies. Furthermore, we can also distinguish a penumbra from oligoemia thanks to the CMRO₂, which is quite stable during oligoemia. But PET studies are not really feasible in clinical practice because they are technically challenging, expensive. There is a limited availability of these studies, and they have also a relatively poor spatial resolution. So the first widely spread imaging that was used to classify the ischemic tissue was MRI. In particular, from studies comparing MRI with PET studies, it was evident that diffusion weighted imaging, DWI, could detect ischemic lesion within some minutes from symptom onset, in particular with increased with hyperintensity in DWI and a reduced apparent diffusion coefficient with a good sensitivity. Furthermore, MRI could allow us also to detect the lesion age, also in wake-up stroke and not known symptom onset. Indeed, a DWI positive lesion, which is not already positive in FLAIR, is with a good sensitivity and specificity a lesion which is younger than 4.5 hours from the onset. But is the DWI positive lesion the real core? Actually not. And this is evident from a phenomenon which is quite common, which is the DWI reversibility. Many studies have described this phenomenon. One of the largest one was a retrospective analysis of the wake-up trial with more than 300 patients, in which DWI reversibility was described in 3 different waves. First, a volumetric analysis in which about 20% of patients showed DWI reversibility. Then a voxel-based analysis in which almost all patients, 99% of patients, showed some kind of DWI reversibility, while the most restrictive definition, so a relative voxel-based DWI reversibility of more than 50% of the lesion, was present in 18% of patients, with 3% of patients presenting a complete reversibility. From subsequent meta-analysis, we know that there's a pooled prevalence of 26% of DWI reversibility. Predictors of this phenomenon are the use of different ADC threshold from the conventional 621, early treatment reperfusion, the absence of perfusion deficit within the DWI lesion, and more distal lesion, while it is debated whether white matter or cortical region have more frequently DWI reversibility. And as for the CT perfusion, we are even more distant from the tissue level. This is why, this is because all the data we have about tissue classification in CT perfusion were based on study comparing CT perfusion with MRI, which is also a surrogate of metabolic perfusion. We know that previously cerebral blood volume was used to detect the core in CT perfusion, but it was not precise, especially in white matter. And then, as we can see from the area under the curve of this study, the relative cerebral blood flow was set as the best parameters to detect the core as compared to DWI lesion. Actually, 38% should be the most accurate. But even though with this threshold, it is evident that they are not stable over time. Actually, as it was evident in this study from the STAIR, there was a relationship between the optimal definition, optimal threshold of the core, both for relative cerebral blood flow and Tmax, and the time from imaging to reperfusion. So once more, our definition of core is not so precise. And this is evident also from some clinical studies that have highlighted both core overestimation and underestimation with CT perfusion. As for the overestimation, this phenomenon is called the ghost infarct. So it is commonly defined as a difference between the CT core volume as defined in acute setting and the 24-hour infarct volume more than 10 milliliter. Its prevalence is varying across studies from 6% to 60%, and also the volume overestimation varies up to 30 milliliters. It seems that it's more frequent in the younger patient and earlier time from symptom onset to imaging. It is debated if it is more common in poor or good collateral status, but it should be more common in patients with increased hypoperfusion intensity ratio, which is a sort of tissue-based collateral assessment. It is also more common in patients with successful reperfusion. And as for core underestimation, we talk about perfusion scotoma. These are the patients who have a lower aspect, so in native CT have a large core, but show a low core infarct volume in CT perfusion. It is quite frequent, about 25%, and it is most common in late time window or in patients who have a partial recanalization at time of imaging or have a really good collateral status. As for penumbra, our definition comes from a MRI study comparing PWI imaging with PET studies. From these studies, it was evident that the best definition was, as evident from the area under the curve, the time to maximum more than 6 seconds. And this definition in MRI was just translated to CTP, creating another possible error. So it's like we're living in the allegory of the cave of Plato, in which we are not looking at the reality, but we are just looking at shadows. So we think we are looking at ischemic tissue and metabolic perfusion, but we are looking just at imaging surrogate. From this point of view, capillary and metabolic perfusion could be a novel method to help us to better define ischemic core and ischemic penumbra. Everything started from the observation that there was a discrepancy between the magnitude in cerebral blood flow changes and the corresponding changes in the cerebral metabolic rate of oxygen. The hypothesis was that this discrepancy were dependent on different capillary flow patterns that might affect the efficacy of oxygen extraction fraction. Indeed, in vivo study showed that erythrocyte flows in capillary is not the same in all capillary. It is quite heterogeneous. So from this was created the concept of capillary transit time. Capillary transit time is described as the time available for blood tissue diffusion exchange before the blood leaves the tissue, and it's a ratio between the capillary volume and the blood flow. As said from in vivo brain models, this capillary transit time is not homogeneous, both in resting state and this state of reduction of perfusion pressure, but it's heterogeneity. So we talk about capillary transit time heterogeneity. Indeed, while cerebral blood flow determines the supply of oxygen to the tissue, the capillary transit time heterogeneity affects whether this oxygen will be uptaken by the tissue. And during ischemia, we have a reduction of cerebral blood flow with a consequent capillary dysfunction, so an increase of capillary transit time heterogeneity. So, starting from this hypothesis, Professor Ostergaard and Jespersen created a model to determine the combined effect of cerebral blood flow and capillary transit time heterogeneity on the oxygen extraction fraction in different settings, both resting state and reduction of increase of cerebral blood flow. This model is represented here, and everything starts from a single capillary in which we have 3 different compartments where the oxygen is bound to the hemoglobin, then to the plasma, and then to the tissue, with a constant K diffusion between plasma and tissue. This capillary would respond to an equation of set capillary length, which is equal to blood velocity per transit time. When we transpose this this single capillary to the whole capillary bed, this transit time becomes the capillary transit time heterogeneity. From the mathematical point of view, the capillary transit time heterogeneity corresponds to the standard deviation of the mean transit time. So after creating this model, Ostergaard and Jaspersen tested it with different cerebral blood flow and CTH values. It is what we see in these images on the right side, and tested the effectiveness of this model using already existing data from literature from in vivo models, which had oxygen extraction fraction data and cerebral blood flow data, and showed that this model was actually effective predicting the oxygen extraction fraction. It did what they found was that during hyperemia, so an increase of cerebral blood flow, there is a reduction of CTH, which improves tissue oxygenation, while during hypoperfusion, so a reduction of cerebral blood flow, we have an increase of CTH compensating the reduction of cerebral blood flow and securing tissue oxygenation. Then there are cases in which there is both an increase of CTH and increase of CBF, and this increase is really high, creating a malignant situation called malignant CTH. After this theoretical model, subsequently Morrisden and colleagues tried to transpose it to MRI perfusion. So they created a statistical approach to use PWI images to calculate CTH and consequently OEF. This model was then tested on 7 acute ischemic stroke patients. What they found was that the model, including both MTT, CBF, and CTH, could predict better the final infarct lesion, the follow-up lesion, than the conventional standard SVD technique. After that, the largest application in clinical was in the Horus preconditioning studies. In the Horus preconditioning study, all the patients underwent to an acute MRI with PWI images. So to test the efficacy of capillary and metabolic perfusion, Eggendal and colleague analyzed the images of more than 100 patients with non-lacunar anterior circulation stroke, and then they evaluated through a voxel analysis PWI within the hypoperfused area, so the DWI positive area, which had also a hypoperfusion evaluated with mean transit time. They evaluated both the classical parameters, so CBF, MTT, and so on, but also the metabolic parameters, so capillary transit time heterogeneity, oxygen extraction fraction, and cerebral metabolic rate of oxygen. Furthermore, as CTH could change also in response to the macrovascular hemodynamic, could be influenced. They also used another parameter that they called the relative transit time heterogeneity. This is a ratio between the CTH and the mean transit time, which should show the real microvascular hemodynamics independently from the effects of global hypoperfusion. So what did they do? First, they tested the result of applying this model on their population to create a computational model which could describe different phases of acute ischemic stroke according to the behavior of the different parameters. So they classified 3 different phases. The first phase is the one in which we can see a reduction in cerebral blood flow, so a reduction in perfusion pressure. In this phase, the relative transit time heterogeneity as well as the capillary transit time heterogeneity start to increase, and so does the oxygen extraction fraction. Subsequently, there is a phase in which CTH and RTH increase even more. So we have a high heterogeneity of capillaries because of capillary constriction. And finally, in the third phase, we have a reduction of capillary transit time heterogeneity and relative transit time heterogeneity. This is because in the first phase we have an homogenization of the capillary bed because of capillary occlusion. They called this third phase the no-flow phase. So this was the theoretical model they created with the data. Then applying it to the real clinical data, so to predict the final infarct volume, what they found was that classical perfusion parameter, in particular cerebral blood flow, could be useful to predict the risk of infarction, but just in recanalized patients with a threshold type relationship, while in patients not recanalized, CBF could not predict reliably the final infarct volume. Indeed, a large proportion of patients of tissue which had preserved cerebral blood flow on admission finally went to infarct. On the other side, the capillary perfusion, in particularly the relative transit time heterogeneity, was better also in this patient in defining tissue at risk of infarction. After that, another application of the metabolic perfusion on clinical data was done by the Lyon group. In particular, they focused on the DWI reversibility phenomenon that we have already seen. We are so talking always about MRI studies. We know from PET studies that in the penumbra there is an hypoperfused region, so we've reduced cerebral blood flow, but we've increased the oxygen extraction fraction and relatively preserved the cerebral metabolic rate of oxygen. So what was the hypothesis of the investigators? So the hypothesis was that DWI lesion, which will go to reversibility, would have increased oxygen extraction fraction. To do so, to test this hypothesis, the Lyon group analyzed the acute MRIs from 182 patients from the hibiscus stroke cohort and compared the acute perfusion imaging to the control at 6 days with tissue flare for the final infarct lesion. This is how they did it as for the imaging protocol. So first, they did a visual assessment within the DWI lesion to detect if OEF was increased. And OEF increased was defined as an increase of more than 2 color scale compared with the normal contralateral side. Then they did also a voxel-based analysis with OEF and CBV and cerebral blood flow maps in the region that went to reversibility as compared to the one which did not reverse. These were the results. First, we can see that a high proportion of patients had DWI recovered region, more than 80%. If we just take the patient with more than 3 milliliters of recovered region, these are still 30% of patients, which is in line with other reports. From the graph, we can see that OEF in recovered region was increased as compared to not recovered region. And indeed, there was also an association between the increase of OEF and the final volume change. Indeed, most of region with OEF increased recovered, about 95%, while just 9% of the regions that recovered had a low OEF. But this was still for MRI. What about CT perfusion? The first study about CT perfusion testing metabolic perfusion was this study from the Korean National Inpatient Database. The study is focusing on the over and underestimation of core that we've talked about in CT perfusion. Of course, the hypothesis is always based on what we know from PET studies. So, ischemic core, we have both reduced CBF and reduced cerebral metabolic rate of oxygen, while in penumbra we have still some sort of preserved, relatively preserved cerebral metabolic rate of oxygen. So, the hypothesis was that the core volume as defined by CMRO₂ would better predict the infarct lesion as compared to the classical CBF definition on CT perfusion. So in the first phase, they needed to find an optimal threshold of CMRO₂ to predict the final infarct core, and in the second phase, they compared it with the CBF volume. The comparison was in 76 patients between the CT perfusion at admission and the DWI lesion performed within 90 minutes after the CTP and before any recanalization reperfusion therapy. So this is what they found. First, the best threshold of CMRO₂ was set at a relative CMRO₂ lower than 26%. Then they could see, as you can see in these images, that the core definition of CMRO₂ was more coherent with DWI than the relative cerebral blood flow definition, with a volumetric bias between DWI and CBF that was about 40 millimeters, and between DWI and CMRO₂ CMRO₂ that was less than 2 milliliters. You see that in some cases there were also lesions that were not detected by relative cerebral blood flow threshold, but were actually detected by the CMRO₂ definition of core. Finally, we will talk about the no-reflow phenomenon. So we skip from the first and acute part of ischemic stroke, and we go to the setting after reperfusion. No-reflow phenomenon is one of the possible explanations of the futile recanalization. So the patient where, despite a successful recanalization, we don't have a good clinical functional outcome. It is well known since the 1970s as an absence of perfusion in the parenchymal microvasculature after an ischemic injury, even though the perfusion has been restored in the main artery. It is calculated that about 1/3 of patients would present with no-reflow phenomenon. It is a really complex phenomenon which involves both vascular wall structure with edema of endothelial cells, endovascular factors such as formation of microthrombi, platelet and neutrophil aggregates, but also extravascular factors such as vasogenic edema and blood-brain barrier disruption. The problem is that to date we don't have a reliable method to detect it in acute ischemic stroke patients. Some studies have tried to detect the no-reflow phenomenon in acute ischemic stroke patient, but with contrasting results. Two of the largest studies are the studies from the Melbourne group, which defined the no-reflow phenomenon as an interside asymmetry of relative cerebral blood volume or flow within the infarct lesion at 24 hours. With this definition, no-reflow phenomenon was detected in the first studies in 25% of patients, and in the validation study in 20% of patients. Most interestingly, this definition of no-reflow phenomenon predicted both futile recanalization, so the poor functional outcome at 90 days, as well as hemorrhagic transformation in both studies. But other authors have proposed a different definition. Here I present you another one from the Bern group, but actually there are also other studies trying to detect no-reflow phenomenon. So in these studies, more than 200 CT perfusion at 24 hours were analyzed after successful reperfusion. The authors classified the patient in 4 different perfusion patterns. The first was the normal perfusion, which was the most common, then hypoperfusion, hyperperfusion, hypoperfusion, and mixed perfusion. The first data is that half of patients had some perfusion abnormality at 24 hours. So something is happening there, even though we have passed the recanalization time. The other important data is that just 70 patients, so just 6% of patients presented hypoperfusion within the infarct lesion. So it seems it is quite rare, and it's not it's really different from the prevalence we've seen in the previous study. So with our group, from Sapienza University, we decided to test whether capillary perfusion and in particular relative transit time heterogeneity could actually detect the no-reflow phenomenon and indeed predict futile recanalization, starting from the computational model of Engedal, which described the third phase of ischemic stroke, so the no-flow phase, as a reduction of relative transit time heterogeneity. So we analyzed data from a patient with anterior circulation LVO with successful recanalization who had 24-hour perfusion MRI. We excluded patients with parenchymal hemorrhagic transformation, and in the end we obtained a population of 150 patients for our analysis. As for our imaging protocol, we defined our region of interest with an automatic infarct core definition from the Cerker software, which uses both FLAIR images and DWI and ADC images to detect the final infarct core. With this definition and also setting a region of interest in the contralateral hemisphere, a mirror lesion of normal brain tissue, we detected all the different conventional and metabolic perfusion parameters. Here you see some example of two of our patients and the CTTH, RTH, and CBF maps within the infarct lesion and within the contralateral mirror lesion. So these are all the data that we collected, and we focused particularly on the relative transit time heterogeneity. To have a more precise detection, we define our definition of no-reflow with the ratio between the RTH within the infarct lesion and the RTH in the contralateral hemisphere. Our definition of microvascular impairment was any reduction of RTH, so RTH ratio below 1. So this is our population. You see that 58 patients over 154 had reduced RTH. Main difference were about final MTC score and going to recanalization time. These are the results about our primary analysis. So patient with reduced RTH had more frequently poor outcome at 90 days, defined both as a modifier Rankin scale 2-6 and 3-6 at 90 days, as well as they were more frequently dead at 90 days. This was also confirmed in our multivariate analysis, which was adjusted for several covariates, such as duration of the procedure, but also the volume of the infarct lesion. And indeed, this is evident also from the Grotha bars. We also tested some early neurological outcome, and what we found was that patients with reduced RTH had more frequently failure of early neurological improvement, both at 24 hours and at 7 days. This is what is described in these graphs. What you see in the green square are actually the patients who presented the microvascular impairment, so RTH, relative RTH lower than 1, and the failure of early neurological improvement. So to test our data, we also performed a sensitivity analysis excluding patients with MTC score 2B, which confirmed our data both for 90 days outcome and for early functional outcome. So indeed, we found that lower RTH ratio was associated with futile recanalization and failure of early neurological improvement, which is in line from the computational model proposed by Engedal, so with the third phase of no-flow. And this could be, this data need to be validated, of course, also in a different population, but could be a new way to detect no-reflow phenomenon. In conclusion, classical parameters for both MRI and CTP do not reflect the real metabolic state of ischemic tissue and the real ischemic core and the real ischemic penumbra. This is why this is because the capillary transit time heterogeneity should be taken into account. Indeed, other markers such as oxygen extraction fraction and cerebral metabolic rate of oxygen might give a more precise definition of both ischemic core and of tissue at risk. Main limitation of this approach is that we have a lack, of course, of comparative studies with positron emission tomography. And finally, relative transit time heterogeneity might help to detect capillary obstruction and occlusion after successful recanalization and hence the no-reflow phenomenon. Thank you.
Thank you very much, Ettore. So if people have questions, don't hesitate to write in the QA section. And I would just have like a small remark about the, so we talk a lot about the RTH map, and in Cercar it has another name, it's called COV, coefficient of variance. So just so you know, every time you see RTH, it can be also called COV. So don't hesitate if you have question. So we have a question from Alejandro Luzardo. Very good presentation. Thank you very much. How do you think OEF could predict no-reflow phenomenon?
Okay. Thank you for the question. Actually, I would expect that in no-reflow phenomenon we would see like a mottled pattern within the infarct lesion, as it was described actually in animal models. So I would expect not generally an increase or reduction of OEF within the infarct lesion, but I would expect some region which have increased OEF within the lesion and other lesion with reduced OEF.
Another question from Professor Chatterjee. Is it possible to calculate the post-treatment infarct volume using a 24-hour CT scan rather than the MRI following a successful thrombectomy?
Okay. Actually, you will correct me, Aurelia, but I don't think that we have with native CT, there is with native CT the possibility of final infarct volume with the software. But if you are performing a CTP, you can use that. Is it correct, Aurelia, for CTP?
Yeah, you need CTP to be able to have the volume calculation, yes.
Yeah, you can have just the calculation of final aspect, which anyway it's some kind of surrogate at 24 hours.
Thank you. If there's any other question, I think that we can take another one or two. And if there's more precise question asked, do not hesitate, and we will get back to you by email if needed. In any way, do not hesitate to come back to us. We can still put you in contact with Ettore. And if you have any question in the following days, do not hesitate to come back to us. Thank you very much again, Ettore.
Thank you.
And thank you all of you for being this part of this webinar once again. And have a good night.
Have a good night.